Dear colleagues, it's a pleasure for me to be again with you for those other moments of obstetric anesthesia. Thanks again to the organizing committee and the scientific committee and the National Society of Anesthesia and Critical Care and Pain Management of Lebanon for this kind invitation. In this session, I will talk to you about key safety challenges in obstetric anesthesia, and you will see that as obstetric anesthesists, we are also importantly implicated in patient safety. My disclosures are the same, and I have no relation with this conference in terms of conflicts of interest. To talk about key safety challenges in obstetric anesthesia, I chose to introduce first the topic, then we'll talk about medication safety in obstetric anesthesia, airway management, postpartum hemorrhage, team training in critical situations, and we will finally treat the topic of organization of our obstetric departments. Concerning the introduction about patient safety, as you know, in 2010, many national societies in Europe signed the Helsinki Declaration, which included lots of key points for which anesthesiologists should be implicated to increase patient safety, including equipment and drugs, preoperative assessment and preparation, syringe labeling, difficult fail intubation, malignant hyperpyrexia, anaphylaxis, local anesthetic toxicity, massive hemorrhage, and infection control, as well as postoperative care, including pain relief. As you can see, on all those topics, the obstetric anesthesiology is implicated. It is applicable completely to obstetrics. But some are more specific to anesthesia in obstetrics. Just to remind you also the trends of side effects or adverse effects in obstetric anesthesia. And as you can see in the period which was assessed in this survey, where they analyzed more than 8,000 anesthesia-related side effects and complications in almost 15 years period in Canada, what you saw is that when general anesthesia was implicated, there were more complications. When complicated GI alone versus neuroaxial block, you multiplied by 2 the risk of complications. When general anesthesia followed a neuroaxial block as compared to neuroaxial block alone, you were more prone and you had a risk of complications multiplied by 7, probably due to the emergency context. Serious of those side effects, 9% were severe, and the most common adverse event was PDPH, postural puncture headache. We had in this period an overall low rate of failed intubation, and effectively the complications were more prone to occur during cesarean delivery than during vaginal delivery. Another important fact is that some parturients were more prone to having these complications, those with cardiomyopathy, those with eclampsia, and those also with obstructive sleep apnea, obese patients. Another important thing is the trend of those complications a long time. Practice has changed. Anesthesiologists got more and more involved in safety, and as you can see here, the rate of complications also went down progressively along this period. You can see that also in the maternal death report in both between 2022 and 23, that the rate of maternal death, although is increasing, most of the causes are indirect causes and not related to anesthesia. In fact, anesthesia was not reported as a cause of maternal death between all this period between 2020 and 2023. Although anesthesia is not implicated, anesthesiologists are implicated in the peripartum period care, and we should be aware of that to improve quality of care and to improve also patient safety. Medication safety is also an important issue in obstetric anesthesia since we are using lots of local anesthetics, lots of different drugs, and different routes of administration, which is the neuraxial route. As you can see in this paper published a few years ago now, but which still is important, you can see that medication errors or routes of administration are very frequent, or the most frequent are due to epidural medication, which is administered into an IV route, IV medication into an epidural, or IV medication, which is injected intrathecally. So the neuraxial route is a source of errors, which can be really lethal. And let me remind you, the many or too many accidents there have been using tranexamic acid, which was confounded with fentanyl or other local anesthetics, and which was injected into the epidural or intrathecal space, causing a few maternal deaths totally avoidable, and which made that there were some alerts from the World Health Organization, but also from the FDA in the United States to make all the anesthesiologists aware of the rare complications associated with the use of neuraxial tranexamic acid injection. These recommendations took three measures. First, informations to anesthesiologists about the danger. Second, try to treat the local risk and develop some risk management strategies and protocols to try to avoid this error of routes of administration. And the third measure was to implement those protocols in all the units, in all the maternal units. Another important measure to take, and I wanted to remind you that there are some recommendations for safety medication practice in general in anesthesiology, but which are also applicable to the obstetric environment, with a special interest in the use of prefilled syringes, so you have less preparation and less risk of medication error. And then some color-coded syringes labels also, and then all a series of preparation of your chart. I recommend you to read these recommendations and maybe implement them on your anesthetic charts and in your departments. When we talk about safety in obstetric anesthesia, we will talk about airway management. Just remind you, although it is quite old now, it's been 10 years since the publication of the OA-DAS guideline for difficult intubation in obstetric patients, but still remind you that we have some specific algorithms which could help us to improve the risk of failed intubation or failed intubation and failed ventilation, which can lead really to maternal death, and which was the cause of many maternal deaths in the past. When it comes also to general anesthesia and airway, remind you also that we have new disposals. Video laryngoscopes have been introduced progressively in many units. Their prices have gone down, so it's a lot more affordable to have them. And you can see in this survey we performed between 2019 and 2022 that the authors showed that there was a progressive increase of the use of these video laryngoscopes in an obstetric environment. with really very low rates of failed intubation. Well, null in this case, no case of failed intubation, and effectively the rate of intubation at the first pass was quite high, and only 3 cases with uh, with an intubation success after 3 attempts. So this implantation of video laryngoscopes in the material units is really progressively effective, and some authors recommend that we have them, but not only have them, use them for obstetric patients, which are probably more difficult to intubate than standard patients in standard conditions. Talking also about airway, we can talk also about the development of this second generation of laryngeal mask, supraglottic airway devices. And in this systematic review, the authors gathered 13 articles with almost 8,000 patients and determined that, well, why not use them for a cesarean section under general anesthesia? But we cannot do that under any circumstances. So this algorithm they developed helped us to take the good decision. First, determine the risk of aspiration. A patient with high aspiration risk maybe should not be proposed a general anesthesia with a laryngeal mask. And then an endotracheal tube should be inserted. Then, if there is no risk of aspiration, we should see if the patient is correctly fasted. If the patient has eaten a couple of hours ago, maybe we should use the anticipated difficult airway protocol published by IAA and as we've mentioned before. And in case the patient is adequately fasted and has no risk of aspiration, we should see if there's an anticipated difficult airway. In case there is not, then maybe supraglottic airway could be used. Although if a difficult airway is anticipated, maybe we should intubate the patient. So to conclude about this, second generation LMAs can be an excellent option in case of non-obese patient with no risk of aspiration and no risk factors for difficult airway. In case of risk for ventilatory difficulty, we should also mention it, and you probably propose a general anesthesia under tracheal tube. The aspiration risks are basically high BMI, gastrous reflux, non-fasting patient, diabetes mellitus, malampathy 3 and 4 patients, and patients with limited mouth opening and preeclampsia. In those patients, maybe laryngeal masks are not the optimum technique. Another important issue is the risk of aspiration. And I wanted to show you this article published also last year because aspiration risk has decreased significantly over the last years. In fact, in this study, the authors assessed 11 years, almost 50,000 cesarean deliveries. And among all these cesarean sections, almost half of them were performed under general anesthesia, and only 0.4% were admitted to the ICU. And among all these, only 3 cases of aspiration were observed. Of these 3 cases, 2 were under general anesthesia, which represents an incidence of 1 in every 11,000 cases, and 1 other was observed in a patient under spinal anesthesia who received also deep sedation. So the incidence is quite low, not inexistent, but selecting well the patients, maybe we can also maintain these high rates and use some other strategies for general anesthesia in case we require them. Talking about postpartum hemorrhage now, just remind you that some guidances were published recently for an optimum first diagnostic of severe postpartum hemorrhage. And if you have symptoms like tachycardia, pallor, hypotension, critical values in blood gas analysis, a shock index superior to 0.9, a high lactate level, oliguria, excessive volume requirements, inappropriate fear or restlessness, or coagulopathy, then this patient should be transferred to an ICU or should be monitored very, very strictly to see how it goes and if there is no further complication. And we should start applying some PPH protocols. Talking about protocols, the authors of this guideline, of this recommendation, show us that we should first diagnose the hemorrhage and then start basic patient management. Search for hyperfibrinolysis, especially in special cases of causes of hemorrhages, and then guide our hemostatic treatment based on the results of viscoelastic tests. We should be also aware that after PPH, patients who receive procoagulant factors are at risk of thrombosis, so thromboprophylaxis is important. And they are at risk also of maintaining an anemia, for which an iron supplementation can be very useful. We have seen an evolution also in the resuscitation of severe anticipated hemorrhages thanks to the use of those REBOA balloons, intra-aortic balloons, which are inserted in the aorta, in the third part of the aorta, and which can, well, be associated with the resuscitation, and in a multidisciplinary team management can decrease significantly the risk of death, but also of severe maternal postpartum hemorrhage. As you can see here, usually patients are mostly proposed a regional block, and this block is usually converted into a general anesthesia in this series of 47 cases, which we published this year in the European Journal of Anesthesia, together with 4 centers in Europe. Concerning now team training and critical situations, it's important that we get trained, and we have many teaching tools, partial task trainers, hybrid simulation, virtual reality, standardized patients, and mannequin-based simulators, which help us improve our performance. And effective communication seems very important also in our obstetric environment, since we are together with nurses, with midwives, with obstetricians, and pediatricians. And so it's important that we develop very good communication skills. It's important also that we don't forget important factors and important aspects of the management. So the use of cognitive health for crisis resource management seems an important tool to help us. Thanks to all these measures in the last year, we have managed to improve safety, that's to say, improve management of PPH, improve communication, improve also share understanding of complex clinical problems. And this leads to really an increased team performance, an increase or improved maternal outcomes, and an increase of patient safety in the end. This is possible thanks to organizational changes and adaptations of our obstetric departments. It is true that we published also in 2020 these minimum standards of care for obstetric analgesia and anesthesia departments, which include aspects affecting human resources, technical equipment, preoperative evaluation, initiation of labor, maintenance of labor analgesia, conversion of labor epidural analgesia into anesthesia for cesarean delivery, standard management for cesarean delivery, high-risk obstetric patient management, postoperative care, and maternal cardiac arrest. So these 10 domains are really important because they state really what any maternal unit should have for an adequate obstetric anesthesia care. It is true that the human resource factor is important, and in fact, manpower differs quite a bit between countries in Europe because we have differences in training, in practice, in autonomy of the residents, and also availability of full-time dedicated anesthesiologists, and also the presence of staff anesthesiologists for obstetric patients. So this can be a problem, but we have to be aware of that and adapt our departments in consequences. That means also that we should try to aim at a standardization of training and practice, and the development of fellowship programs in scientifically well-respected institutions could be very, very appropriate for that, so that all obstetric anesthesiologists or all the anesthesiologists who attend obstetric patients have the same training and have the same way of treating those patients. To finalize this talk, just remind you that obstetric anesthesia is a risky environment. We are not in the OR all the time. The labor ward is very different, and we have to be prepared for that. All the domains of patient safety must be considered in obstetric care. Specificities, the specificities to be considered are related to the environment, labor ward, plus the obstetric operating room. And the patient also, we have not just one patient, but two, the mother and the fetus. Communication with all team members is really crucial if we want to do a good job. And we are not alone. We are working in a team, so we have to count on that. And finally, the training and organizational aspects will help us to improve safety in obstetric care. Thank you for your attention, and I will be able to attend all your questions in a few moments. Je pense que c'est là est pas mal.